as well as interaction with ongoing therapy, be it levodopa or carbidopa. There's papers that show that these medications should definitely be given and continued, even on the day of surgery. And independent of papers looking at total joint arthroplasty, all these patients with Parkinson's disease, physiotherapy is most effective if it is guided and supervised by a trained professional. Arguably, it probably is in most cases. But in addition, the physiotherapy should be at about 45 minutes following administration of medication. Opioid drugs affect the dopaminergic pathways and hence should be avoided because they are going to have implications for the patient's mental state as well as their Parkinsonian symptoms. Interestingly, the paper highlights the role of non-steroidal medications for analgesia and picks out ketorolac with the sort of unclear why they highlight that specific one, but as an intramuscular administration 4 times a day for the 48 hours perioperatively. I've actually not seen ketorolac used here by the pain team or anaesthetic team, so that would be something interesting to raise with them. But perioperative risks probably outweigh the benefits for patients who aren't able to tolerate a regional anaesthetic or non-opioid analgesics, which I thought was a fairly bold claim to make. So interactions between the specific Parkinsonian medications and analgesics should be addressed, and these should be raised with the neurology team prior to surgery. That being said, there's no data looking at how to manage these interactions in any joint. And as we know, Parkinson's disease patients have a much higher risk of falls, and hence nursing vigilance is recommended in that perioperative period. Because these patients it's been independently shown that they do fall more often than standard. Looking at management from an orthopedic perspective, the paper states that, and this is mainly based on author experience and a number of case studies rather than any actual well-controlled trials, that cruciate retaining and posterior stabilized prostheses are probably only indicated for mild disease with normal quadriceps and hamstring function. The authors prefer cruciate retaining condyle restrained or hinged prostheses due to a higher incidence of subluxation of posterior stabilized components, as we can see there in the second and third. Again, this is based more on case theories and experience rather than any true comparison. Hinge prostheses may be the safest option in patients with severe disease. So activity levels of these patients, because of their underlying functional loss, means that a lot of concerns regarding a fully constrained prosthesis are. And this is, their authors state that their recommendation is based on the severity of the flexion deformity and rigid prosthesis. There is no literature regarding what particular surgical approach should be used, so the patient recommends that the surgeon choose the approach most familiar to them, which makes sense. Patients need to be assessed regularly post-operatively for surgical site infection, as well as an intact extensor mechanism given their tendency to rupture. Assessment for flexion contractures, both pre and post-operatively. These can be managed or mitigated with serial bracing, splinting, casting. And the paper highlights that the evidence for CPM globally in total knee replacement is somewhat equivocal, looking at some papers, and particularly so in patients who do have abnormal extensor and flexor mechanisms. They also need to be assessed for patellar tracking. Parkinson's patients also have a higher incidence of sialuria or production of saliva, which makes them much higher risk for silent aspiration in the perianal period, which is something to be aware of in the ward. Saylor et al. Described the use of Botox to improve flexion contractures following total knee replacement, and use of this in the extensor mechanism, flexor mechanism, as well as gastroc in some papers. does lead to improved and sustained range of motion at long-term follow-up. Again, 11 patients in that study. And orthopedic and neurological communication should continue post-discharge and transition setting, particularly with regards to management of the patient's functional status, as well as early intervention, early identification and intervention of any extensive mechanism rupture. So the article goes on to summarise or say that there is very limited data to aid and predict outcome in total knee replacement in these patients, but does make a number of recommendations, most of which we've sort of worked through here in the paper. So only should be considered once non-surgical measures have failed and when the indication is debilitating joint pain rather than functional. The author's preference is crucially at retaining condylar constrained or hinged knee devices. The use of sciatic blockade or hamstrings Botox injection, not using CPM, using well-padded braces to manage contractures if they arise. Contraindications to total knee replacement. I don't think patients with preoperative delirium would be performing elective surgery on anyway, so I'm not quite sure why that's been highlighted there. Regional anaesthesia is far preferable to general anaesthesia, as we've said there. Opiates should be avoided. Multidisciplinary team should, of course, be involved, again, probably as they should with any joint replacement. They do better in patients with mild disease. That said, the evidence is very limited. Severe flexion contractures don't do well at all and have a high incidence of mechanism rupture. And there's evidence there, of course, that if they don't respond to a and that's it. Thank you very much. Is there any questions?
Actually, is Parkinson's these days mild disease with treatment?
No, so essentially it's a degenerative condition and the treatment is symptomatic. Unfortunately, as the dopamine receptors or dopamine producing cells drop off, they end up becoming unresponsive to unclear as to the role of the deep brain stimulation and that they do now. But my understanding is that it is essentially degenerative.